So my name is Grace Irvin. I am the prevention coordinator here at Chestnut Health Systems. I am overseeing the Logan Mason ROSC, which is who is supporting this webinar. We are very excited to have Brent Van Ham from SIU Medicine joining us here today. So Brent holds a master's degree in Rehabilitation Counseling from Southern Illinois University and is a Certified Rehabilitation Counselor specializing in substance use disorder prevention, treatment, and recovery. He is also a registered nurse with many years of experience in multiple clinical settings, including physical and medical rehabilitation and medical surgical care. Brent is especially interested in novel approaches to address health and resource disparities affecting rural and minority populations, focusing on behavioral health, addiction, and asthma management. So for the ROSC, we are very excited to have you here today, Brent. And for those who don't know what the Logan Mason ROSC is about, we are with two smaller rural counties within the state of Illinois. Our bigger towns within Logan County is Lincoln, Illinois, and in Mason County, it's Savannah, Illinois. And we, part of our strategic plan is focusing on medicated assisted recovery. And we are partnering with Ford County ROSC with our Reframing Recovery Stigma Reduction campaign. And each quarter we have a different focus on a different subject matter. And this quarter was medicated assisted recovery. So if you aren't part of our social medias, please go ahead and join ours, Logan Mason ROSC, at facebook.com. And then you can connect with our Instagram from there as well. But we are very excited to have this as part of our webinar series and having you join us, Brent. So thank you. You can take it away. Oh, you are muted.
Okay, thank you. How's that?
Perfect.
So I really appreciate being here, Grace, and thank you to everyone who's attending. Recovery-oriented systems of care is pretty close to my heart. I feel like the development of ROSC in Illinois anyway was one of the boldest moves we made for people in recovery and people entertaining recovery, basically making it official that the Illinois Department of Human Services and that SAMHSA, cared enough to actually put money aside and have meetings, for people in recovery. I feel like this has done so much to reduce stigma, which we're going to talk about. And, the end result of that is basically just people coming into care a little bit earlier and with a little bit less hesitation, and how that translates, honestly, is saved lives. So that's why I think it's super important. So I'm about to do the hardest part of my presentation, which is the screen share. So here we go. Okay. I think this is a great subject today. And actually, talking about MAR, MAR, and recovery stigma, it's actually two subjects. We're going to talk about stigma, and then we're going to talk about medication. But they do dovetail very well into each other, and they affect each other. They affect each other both ways. Stigma for people who use drugs and people who are entertaining coming into recovery and people in long-term recovery is a thing, and it does sometimes cause hesitation in reaching out to several services, including medication-assisted recovery. And then we can look at it the other way around. People who are participants in MAR and are receiving medication-assisted recovery on their journey, sometimes they bump into stigma from people actually in the recovery community sometimes who have opinions about the medication maybe being a shortcut or whatever. So we'll talk about that a little bit as well. They definitely fit together. So I work at the Center for Rural Health and Social Service Development. This is a division of SIU School of Medicine here on the Carbondale campus. When I got hired about 6 years ago, I realized that the majority of SIU School of Medicine is actually up in Springfield. So what we do here in Wheeler Hall, that's the building. This is the second oldest building on campus. Anyway, what we do here is a lot of public health outreach. So we're considered kind of the rural public health arm of SIU School of Medicine. And we have several interventions, most of which are grant funded. I'm using my time today, coming to you from the Leadership Center grant, which is a grant from the Illinois Department of Human Services. So the Leadership Grant is a substance use disorder related grant. We have several things going on. You know, we're doing some outreach for overdose and stuff like that. We're also training a whole classroom full of certified peer specialists. So we've got a lot going on. Please, if you have my email, Grace, you're welcome to share my email. If anyone ever has any questions for me, just shoot me an email and it's no problem. Okay, so just getting into it, as I speak, I'm not really going to go into dosages and chemicals real deep today and talk about effectiveness of this versus that. I'm not going to show you a bunch of stats. We're going to talk about medication assisted recovery, hopefully in a way. My goal is to have us talk about it and think about, as we talk, think about how we can present this information to the public and to people that might not be experienced in this subject, because that's where the stigma usually arises. People tend to like fall on stigmatic views when there's a knowledge deficit. You know, knowledge deficits, when we don't know everything that's going on, it can be kind of scary. You know, it can injure our pride, and we can fill in the blanks by assuming things. And I think that's kind of the start of stigma a lot of times, besides just fearing differences and fearing the other, is this idea that, you know, people may maybe kind of feel pressured to form opinions before they know much about, you know, whatever intervention we're talking about. And I'm just telling you, this is my opinion. When we talk about drug use, recreational use, uh, dependence, addiction, when we talk about these things in America, anyone you talk to is going to have an opinion about this. I think that's for a couple reasons. First of all, in America, as Americans, we are opinionated people. And we often feel pressure to have opinions before we know the whole picture. You know, it's almost like an American thing where as soon as we talk about something, we have to state where we stand. So that's going on in the background. And then at the same time, um, you know, there's not a lot of information out there about this. So it can seem a little scary. And, you know, everyone has been touched by drug use or addiction. I pretty much think at this point in America, 100% of us have been touched by addiction, harming our family or at least our friend group. You know, so this is why people have opinions. And I'm not really trying to have us change opinions. I just want to open people's minds to let them know there's multiple paths to recovery. Medication assisted recovery is a tool. It's just one of many. We could be talking about recovery groups in the community as a tool. We could talk about peer counseling as a tool. We could talk about different counseling modalities like CBT and DBT and all this other stuff. Those are all tools. And we know now through vigorous research that not everyone needs every tool. You know, so that's kind of the job of those of us that are in the industry of treatment, the treatment industry, that actually talk to clients, is we sometimes have the chance to sort out, you know, what someone may need or not need, you know. And medication assisted recovery is a very valuable tool for many people, especially in light of, you know, new drugs that come out over the years that have different addictive potentials. And some of them, you know, some of these drugs, like especially when we talk about opioids and fentanyl, these drugs cause prolonged um, post-acute withdrawal syndrome. So this means that even after someone has dried out or gone through that first withdrawal and they've gotten over all that stuff, so they're no longer needing the medicine to not be sick, it's often, especially with opioids and stimulants, you know, someone's brain has still not, their neurology has still not completely adjusted. Up to 6 months to maybe a year and a half, they may be feeling not quite themselves. They may not have the ability to feel pleasure like they used to. And then they have these sneaky cravings that attack them. MAR is a tool that allows people to kind of get back into their lives, enter recovery, and straighten things out and kind of find an even keel. Now, MAR, a lot of people don't want to be on this medication for life. And when we started out talking about these medications, it was assumed that people would be on these for a very temporary time. Vigorous research has shown that it's fine for people to stay on MAR for multiple years. Many people, when they enter recovery on these drugs, they have a pretty well-determined goal for cessation of the medication. And I always tell them, if they're thinking about that stuff in early recovery, is, you have time to figure this out. Now that you're on the med, you have time to figure this out and talk to your physician about a nice and easy timeline for you to come off this medication. So getting into MAR, MAR is a recent language switch, probably about 3 or 4 years ago, from MAT. We used to say medication-assisted treatment. We just wanted to get that language a little bit away from treatment and put it in the recovery sphere. So we're talking about recovery. It's a little bit less passive than treatment, which is kind of, when you see treatment, it looks like it's dictated. Recovery is more, gives the patient more autonomy. MAR, medication-assisted recovery, exists for other drugs besides opioids. Usually when this conversation comes up in recovery groups or in the public, people are automatically thinking about methadone and Suboxone. That's just because that's kind of the primary discussion over the last few years, which is then back related to how much overdose death we've had. Obviously, when we're losing that many people to overdose death, it's very important that we bring that number down. We've been somewhat successful in this. So the MAR for opioids definitely got more attention, but there is MAR for several other drugs that are abused or people become dependent on. MAR is basically designed to do one or more of the following, or probably all of the following for some people. When it's properly administered, medication-assisted recovery medicines reduce risk. Especially when we're talking about opioids and stimulants, they reduce the risk of a person going back out and getting into a situation where they're using drugs that have, that's the problem with street opioids right now is no one is able to determine what kind of dosage is in that medication because of fentanyl, right? So every time someone goes out to get a drug that is not that is illegally sourced, they're playing Russian roulette with the strength of that drug. So we're reducing overdose risks right off the bat if we can switch someone over to these medications. The medications are also designed to reduce cravings for that more dangerous drug, right? So we're going to use an opioid like methadone, which has a safer, a better safety profile to get you off the street fentanyl. So we're replacing a very dangerous and wildly unpredictable drug with a more predictable and a solid drug that has plenty of research behind it. We're providing a steady state for someone. This allows them to recover and get their life back. And this allows someone to do this in early recovery, when someone who may not be doing MAR may be dealing with extreme withdrawal syndromes, right? So they're taken out of the picture for a while. These drugs also, by definition, they're made to reduce euphoria and sedation. These are effects that the user probably wanted when they started using drugs, was that euphoric feeling or a sedation or a break from their thoughts, right? These drugs are, once someone gets on a steady state of these medicines, they're made so they don't create a high or over sedation. So once someone's on MAR and they're solid on it, usually it takes about a week to adjust it right, they don't look like they're on a drug because they're at a steady state. I would like to say that if anyone has a question at any time, you can pop in on your microphone, or you can just pop something into the chat and Grace will read it to me. I have no problem with interruptions at all. So I just wanted to show you a couple examples of MAR. They are not all opioid related, so we're not only talking about Suboxone. MAR for nicotine addiction has been around for like 25, 30 years. I remember it started with Nicorette gum. I really shouldn't be using brand names, but gum that had nicotine in it was used. So that, if you look down on the slide to the bottom, that's NRT, which was a nicotine replacement therapy. And there's several ways that people can do this now. We have gums, lozenges, they even have strips, which dissolve in the mouth. And then there's off-label. We do know that people sometimes can quit cigarettes or even chewing tobacco by using nicotine vaping. Now, that's not encouraged in America because we know nicotine vaping is its own problem, right? Kids are having problems with addiction here. But we do have to pay attention to the fact that many people, a lot of them adults, use nicotine vaping to get off of more dangerous burning cigarettes. And then some of them were able to put that vape down. So it was a step on their way to cessation. Then we have prescribed drugs that are used quite commonly. And this would be, for someone that went in and self-identified to their doctor that they want some help, so they would have to actually reach out to someone in the medical community first. And Wellbutrin is a drug that's used. This is an antidepressant, which honestly isn't used that much for antidepressant uses anymore. Its main use now is for nicotine cessation. Bupropion, also known as Buspar, is a drug that reduces anxiety and doesn't have the euphoric or sedating effects that benzodiazepines like Klonopin or Xanax have. And it's shown great effect in craving reduction for multiple drugs, including nicotine. Buspar or bupropion is especially effective, we've found, for stimulants. And nicotine is a stimulant. And then there's varenicline. I don't know the trade name of that, but this drug is unique in that it is able to attach to the sites that nicotine attaches to. So in the brain on those neuroreceptors, it kind of holds the place. An example of this might be something like Narcan. It holds that place on the receptor site while not creating any type of action. And then the nicotine, when someone does the nicotine and gets the nicotine in their body, it has difficulty attaching to these sites. I just put little pictures. I did want to point out that we have some regional stuff that is really vigorous for nicotine cessation. We have the Southern Illinois Tobacco Prevention Partnership, which is great. These guys have meetings that are very, very well attended. If you want to check that out. And you can look it all up on SIH's HSIDN, which is Healthy Southern Illinois Delta Network page. They have a massive trove of resources for people wanting to quit tobacco. And then, of course, we have a quit line in our state. Many states have a quit line. Moving on, alcohol, which is a major problem in our society. People come into cessation from alcohol for behavioral problems related to alcohol. People also come into alcohol cessation for extreme alcohol dependence, which often requires medical intervention, especially during the early stages. And there's several drugs that are used at different stages as MAR for alcohol use disorder. Withdrawal management is an especially tricky stage for people that need to drink every day or they get sick. For people like that who are at that stage in addiction, if they suddenly quit alcohol and they are physically dependent, they run the risk of having seizures. This can be life-threatening, especially if someone doesn't have the best of health. And they run the risk of getting very, very sick. So in the hospital, if someone is to seek withdrawal assistance, going to the hospital stating, I cannot last 2 hours without a drink, or I go into withdrawal, that person will usually end up on the med-surg floor or maybe even in the ICU. And the primary drugs they will use are tranquilizers that are benzodiazepines. So these are drugs that outside of alcohol addiction act a lot like alcohol does. Xanax, Ativan, Klonopin. Usually Ativan is the one used. So what the nurse does in the acute setting is they take someone's blood pressure and they look at how bad their shaking is, and then they ask them a couple questions. And then they give them medication to alleviate those symptoms. These benzodiazepines that happen in the hospital setting over 3 or 4 days should come down to the point that they're completely stopped. So basically what they're doing is they're easing someone out of a very scary withdrawal situation. Usually this is used in conjunction with blood pressure medications. Barbiturates are rarely used these days, but they can be used, and I think in third world countries, they're still used quite a bit for this. Now, in post-acute withdrawal, this is after the initial sickness and all that, when someone is in their first month or second month of alcohol cessations, we look a lot towards antidepressants. So we have so many SSRIs, I'm not going to name them. And then again, Buspar or buspirone is used quite a bit for anxiety. And it's really special because it doesn't create that sedation that if we were going to continue someone on with, Xanax, they might end up in the same situation with that drug as they were with alcohol. Then we have craving reduction drugs. Naltrexone is famously very good at this for alcohol, and we're using it more and more. The Illinois helpline for opioids and other drugs is now prescribing naltrexone for people who have alcohol use disorder. And so an alcoholic or someone who uses this drug, once they've gotten through that initial stage, the way it works is they take this drug every day. What I've been told is they don't even feel the drug after they get used to it. And then what happens is if they do decide to drink, they find that there's no reinforcement. So it's just like drinking a soda would be for someone. They drink one or one and a half and set it down because it just doesn't create that pleasure anymore. And then we know experimentally now, these GLP-1 drugs that are being used at a massive scale in our country for weight loss, these drugs are showing, we're finding out that they affect appetite for other things besides food. And this was a secondary finding. People who were using GLP-1s for weight loss started reporting to their doctors that they were drinking less. So now GLP-1s are being looked at. They are being used, I think, as a what we would call an off-label drug for alcoholism, and there's a lot of promise here. Of course, weight loss would be a side effect of this kind of use for alcoholism. And then we have alcohol is special in that we have a drug that's kind of antiquated, in my opinion. It's still around, but it's called antabuse. Disulfiram is the actual drug name. And if someone takes this drug after they've dried out, after they've gone through the initial withdrawal, the thought was, we're going to get you on this drug. You take it every day. It doesn't really cause any side effects. But if you should drink while you're on this, it's going to cause extreme discomfort. And what happens is people flush, they get a rash or turn red, and then they become extremely anxious and uncomfortable, and their blood pressure shoots very high when they take antabuse and then use alcohol. So it's a deterrent. And we're finding that this doesn't work the best for recovery. I don't think I can't really quote the data, but I don't think it's very good for this drug. And besides that, it has, the possibility of putting someone in a medical crisis, especially if, say, this person is elderly or frail, and then they decide to drink and end up having this blood pressure spike and all that stuff. So antabuse is just not being used as much as it used to be. More in the favor of these other drugs like naltrexone especially. Although it's not very common, and we're still, I'm not doing this, but researchers are really working very hard on stimulant use disorder. We know that even though opioid use disorder has taken many lives through overdoses and stuff, when we talk to anyone who lives in a rural area, we're going to talk about meth a little bit because people in my area, Carbondale, Illinois, they'll tell you sometimes in communities around me that meth is actually the number one problem and opioids is secondary. So meth is still around. Stimulant use disorder is a major problem. And we've been saying there's no MAR, or there's no medicines for this, but there has been some off-label use of medicines that have shown some promise. Promising medications, again, here is bupropion. And it's thought that what this does is it takes away a little bit of the craving. It kind of equalizes the dopamine in someone's brain. And also it cuts down on that anxiety, right? And, anxiety and craving, they go hand in hand. Naltrexone is being used here. And what's very interesting is recently some researchers have found that in combination, bupropion and naltrexone they seem to be effective. In this is very early data, but what they're doing in these studies is they're giving people naltrexone. One of them's going oral, and one of them is IV, and it is showing that there's a massive decrease in craving. Then there's topramate, and then there's actually long-acting stimulants like modafinil. There's other ones that are mentioned like Strattera, but these drugs are stimulants in themselves, so they're used off-label with extreme caution for someone with a stimulant use disorder. And the idea is, maybe you have ADD, attention deficit disorder, and you're using methamphetamine to basically self-medicate your attention deficit disorder. And it has been found through the years that many people who fall into stimulant use disorder do have ADD. So maybe they could use a stimulant. So the thought is, if we give you a long-term, steady state, low dose stimulant that's not going to give you any spike that causes euphoria, that maybe we can help you, and you'll not have these cravings, and we can get you away from these ups and downs. So I'm sure that there's mixed success with that, depending upon someone's situation. Talking about MAR for opioid use disorder is a big subject because this is where everyone's used to talking about MAR. And I just know from meetings, if I say MAR, most people are going to instantly think about Suboxone or methadone secondarily. But what they're thinking about is opioid use MAR. And again, this is just because opioid use is causing so many fatalities that this has gotten the #1 priority from every funding agency. So methadone is not new at all. Methadone was actually developed in the early 60s, and they started using it. They realized that methadone, although it was developed as a painkiller, and it is still used in hospitals and is given to people even on an outpatient basis for pain control. It's a pretty good pain med, but they realized that it didn't have the extreme euphoria and ups and downs that drugs like heroin and morphine did. So they started experimenting. At that time, there was no fentanyl. I don't even think it had been invented. So heroin, that was a different opioid epidemic at that time in the 70s. That was our last opioid epidemic, and it was heroin related. So in 1972, after doctors had a pretty good success in treating people with methadone, so they were learning MAR as they went along with methadone, the federal government in America got involved. And here this is just opinion, but I feel that some stigma was involved here. And what happened was in 1972, Congress put some very stringent restriction and rules around MAR, specifically methadone, which separated it from medical care. So 1972 is when methadone, although it was new, it exited the physician's office and went to the methadone clinic. And this is kind of this classic picture that people have in their heads when they think about methadone clinics, right? Is this line of people out there in the cold of morning before the sun even comes up, waiting for their dose so they can get on with their day. And they do this every darn day. And this has been our standard of practice for decades. Then Suboxone came out. It came out in the 90s or late 80s, and it was first trialed in Europe. Suboxone, just like all our opioids, was a pain reliever first. And in the early 1990s, which was about the time we were starting our big wave of this prescription opioid situation that happened in our country, they started using Suboxone as an MAR drug. And it was they had research before we did. It was very vigorous and it looked good. So in the year 2000, as things were getting out of control in the United States, we started dosing methadone for people who were addicted to opioids. So this started with the Data Act of 2000, which is the Drug Addiction Treatment Act. And this was bypassed this whole thing where we needed to have a standalone clinic for people with opioid use disorder. So this allowed people with addictions back into the doctor's office to talk about their problems. And we started dosing people from the doctor's office with Suboxone. Now, Suboxone clinics do exist still and are usually attached to rehabilitation centers. So in 2023, the U.S. Congress went a step further and eliminated the X waiver. This is something we talked about quite a bit several years ago, because if a doctor wanted to prescribe methadone or Suboxone, usually this would be a doctor in a rural area that I'd talk to. And, they're like, man, there are a lot of these problems around here. We want to prescribe Suboxone. And then, they had to go through a lengthy training period to do that, and that was a deterrent, especially to busy doctors who have a clinical practice to go and do this weekend training for 3 weekends or whatever it took. Anyway, in 2003, we removed the X waiver. So this basically said, what we said to physicians with this was, you are a physician in the United States and America, and you are able to prescribe opioids for pain. So now, yes, you are able to prescribe opioids for dependence. I think this was a great move. Doctors were already able to prescribe class 3 and class 2 drugs, so why not? Are there any questions so far?
Yeah. So, Kat Hayes asked, what were the names of the tobacco cessation resources that you mentioned?
Oh my, definitely a big one is there's a Southern Illinois Tobacco Partnership. And that's basically, when we talk about Southern Illinois down here, we're talking about the bottom 18 or the bottom 16 counties. But it's by no means something someone in Central Illinois couldn't access. And then Southern Illinois Healthcare Hospitals is a big system down here where I live. They own like 4 hospitals. Anyway, their Office of Community Benefits, over a decade ago, developed the HSIDN, which is Healthy Southern Illinois Delta Network. So this is a site. This is a coalition. We have meetings and coalitions and different groups that focus on different diseases. So HSIDN is very broad. But anyway, over time, they've built out this website to be so comprehensive, it's hard to believe, but it is a resource hub for all of Southern Illinois, and I would say Central Illinois too. You can look up other things here. You can look up heart disease. You can look up addiction. If you were to look up MAR, you're going to find a lot of stuff there and a lot of stuff about opioids, but they have a huge amount of resources for smoking cessation as well. That's HSIDN.
Awesome. That was it. You can continue.
Okay. So, MAT, the way it's used is most of the time when someone comes into MAT for opioid use, we want to have our eye on them frequently. I'm speaking about the provider who is prescribing. And then, we don't want to totally ignore the counseling and the social aspects of addiction. Now, this can differ depending upon who we're talking to. There are people, that came into street use of opioids through the medical route, 100%. And that one time they were taking pills for their back pain. And then as the epidemic took off, the opioid epidemic and took off, and we restricted, rightfully so probably, we restricted and reduced our prescribing, which was totally out of control. There were some people that were in pain clinics that kind of got cut out and went to the street. So, I think these people are in the minority, but there can be people that are addicted to opioids who never really went the route of euphoria or partying or any kind of street use. They just fell into pure physical dependence. Okay. I personally feel like it's hard to have physical dependence for any large amount of time without getting a psychological dependence as well. But I suppose there are people that could use MAT and get off opioids and be fine without counseling. But for most people, we're going to ask them to do MAT alongside of behavioral therapy, psychosocial support, and all those other wraparound services. This could include social support groups like AA and NA and Smart Recovery and Refuge Recovery. This could also include maybe some therapy for trauma. You know, we have found through vigorous research that a lot of people who have opioid use disorder are actually medicating behavioral issues that stem from childhood trauma. So, maybe nipping this in the bud by talking to someone and unpacking that trauma could happen at this time while we're using MAR therapy to stabilize someone. So there's a little diagram of how it looks. MAT goes to behavioral therapy and FDA approved medications, whichever one is chosen. And then we can use methadone, buprenorphine, which is Suboxone, and naltrexone. Now, some of the buprenorphine, like especially the strips, come with naltrexone in them. So they're built in a way that they're not as abusable. Now, Suboxone can be abused on the street, but it's worth noting that people relatively don't really abuse Suboxone for very long because there's a ceiling for the euphoria. And that's what makes this such a successful drug. We're going to see if this plays. Please let me know right away if it doesn't. This is the Illinois helpline.
Around whatever group you're in, somebody there.
It's working.
There's almost no one who isn't affected by the opioid epidemic in Illinois. Every walk of life. Look around, whatever group you're in, somebody there has walked the walk or is walking it or will be walking it at some point. What we're trying to accomplish in the state is to get communities more ready for recovery. The idea being that when we're successful at addressing this opioid crisis, that we're going to have a lot of people in Illinois who are living in recovery.
Help is here.
Help is here.
It takes the community to help someone recover.
Help is here.
We are understanding that when you bring the pieces together, you're more effective. I'm seeing more people saying, how can we do this together?
Help is here.
Help is here. We want to be able to help you be able to get a job, maintain a job, stable housing, have relationships, have a peer group to associate with.
Help is here.
Estoy para ayudarle. We want to meet people where they're at and get them the services that they need. We might find you on the street. We might find you in the hospital after an overdose. We just want to make sure that we can get you into care.
People contemplating recovery often have a lot of fear around asking for help, but actually it's the most important step.
You don't have to go through this alone. None of us should go through this alone.
Help is here.
Help is here.
It is a great reward when you can see people get back their lives and you can see their physical health change. You can see it in their face. You can see it in their eyes. You can see it in the way they talk with you, their commitment to treatment. It's great to see.
Once people reach out and ask for help, they often find that that's the biggest, most important step that they've ever made.
Please ask for help.
Help is here right now.
Can you guys hear me?
Yes, we can.
Oh, okay, so I hope that video played okay. The Illinois helpline was rolled out by the Illinois Department of Human Services and has been very successful in Illinois. So you'll see there's a toll-free number, 833-234-6343. So people with any kind of addiction can call this number. And the way they do it is someone will talk to someone and do their screenings and all this stuff, right? They'll screen someone for everything, depression, suicide, and then, of course, drug abuse. If someone identifies as an opioid user or an alcohol dependent person, the helpline will offer them MAR right there on that call. They'll say, have you ever tried MAR? Would you be interested in maybe looking at it? And if the person says yes, if they're an opioid user or an alcohol user, they'll be forwarded to a doctor who works in contract with this program on that call. So right then they're forwarded to the doctor. If it's opioids, that doctor is able to telemedically prescribe Suboxone right there and then, and they can pick up that med the next day. The way they do that is they prescribe 2 weeks of that medication, and then referrals are made to try to get that person a doctor in their neighborhood. Depending upon where they come from, that may be difficult. We have a lot of deserts for these services. For alcohol, the situation is exactly the same. They'll set them up on naltrexone telemedically for 2 weeks, and then we'll farm that out to a local provider. Naltrexone is a little bit easier to deal with when we talk about getting someone a standard provider because it's not a controlled medication.
Around what it.
Okay, I'm going to switch gears, and I realize my time is short, so we're going to do the quickest stigma training I've ever done in my life and talk about stigma because it affects this whole situation with MAR. Stigma is a part of the whole conversation about drug use. We don't say abuse very much anymore, but drug use, recreational use, drug addiction, drug dependence. There's stigma involved in all of this. People stigmatize each other for differences is what's happening. And stigma is basically viewing a person in a negative way, and that negativity is attached to characteristics of that person, which could be health issues. So they could be behavioral issues or physical issues or a perceived social deficiency. Discrimination, when we discriminate against someone, that's when we enact that stigma. Discrimination is an actual act. That's where we actually reach out and do something that injures someone based on that stigma. So there's a couple types. I'm just going to go into a few. Public stigma refers to negative attitudes that the general public has towards someone because of their condition. And you could think about this as something regional. It might be different in Carbondale than it is in Chicago, than it is in San Francisco, right? When we're talking about people who use drugs. But public stigma is that kind of general negative feeling that people have in an area towards drug users or people in recovery. And that's usually, like I said before, there's a knowledge deficit involved. We have structural stigma. This is stigma that's in our institutions. It may be a relic from old-timey racism or sexism or anything like that. Or it may be just something about us treating a population that's a little bit different than those of us that are working here. So structuralized stigma is stuff that affects people, and sometimes we don't even realize it's because it's kind of built into the system. Okay, I could give several examples here, but one example could be like a health, say a health department that deals with many issues. They're checking people's cholesterol, they're doing WIC, they're doing all kinds of stuff, and maybe someone with a serious drug addiction comes in and they face some stigma because they're kind of a little bit out of the ordinary for as far as their patient group goes. Then we have stealth stigma. This is a result of the other stigmas. Those of us that are in recovery, those of us that may be using drugs, we absorb this stigma around us and we start to adopt this. And if you've been around people in recovery, especially in early recovery and been to any group therapy or anything, you're going to hear stuff about this. This is usually when we're trying to change people's language, say, Brent, you don't really need to call yourself a drunk. You have alcohol use disorder. It's an actual disorder, man. So, stop stigmatizing yourself. So people that adopt these internalized stigma, which is extremely common for people with addiction, they come to expect to be treated negatively when they walk into our offices because they expect people to judge them immediately based on these things or a combination of these things. Addiction being one of them, poverty being one of them. There are impacts to our clinical practice. For the clients, they're going to be reluctant to seek out treatment. This is going to bump up mortality and morbidity. People are not going to get into recovery if they don't survive to get some help. reduced trust and rapport, delayed treatment, poor quality of life as this addiction goes on raging, reduced engagement and adherence to care. If I go into the office and speak to a counselor and I get any kind of stigmatic treatment, and believe me, we feel it when it's given to us. If I get that kind of treatment and it hits home and I feel it in my heart, I'm going to be way less likely to take your advice, for sure. And it ultimately ends up with decreased employee satisfaction. So although the employees may be the people being stigmatic, this is going to affect the morale of the whole place eventually. There's a cycle. So it starts with that public stigma, and then it goes all the way around to someone self-stigmatizing themselves and then dropping out, reducing their connection to what they need. And then, what do? Those of us with substance use disorder, when we feel guilt and we feel like we don't fit in and we're not good enough, we may reach out to that substance again. So we can respond to stigma. We can fight it. When someone comes in, we might realize their head is on a swivel because they expect to be stigmatized. They can look a certain way, easily startled. Emotional escalation can happen quickly because they don't trust us. So if someone's experienced this kind of stigma enough, they adopt it, they self-stigmatize, and they assume when they walk in the door that they're going to be judged and scrutinized. So we need to know that even the front office personnel, who may just be, secretarial in nature and not healthcare providers, they're part of this situation. So any stigma at all that comes towards the patient is going to reduce the success of the visit. Recognizing and responding, if they're grumpy and mean, they may walk in the door with a sour face or be short with us or with others or refuse. They're displaying this toughness to kind of short circuit the situation. What they're doing is they're rejecting us before we reject them. It's a preeminent strike. So what do? I realize my slides were just a bit behind. I'm so sorry about that. This is what we want to do. We want to greet every single person as soon as they walk in the door, valuing their privacy. Humor is a great tool for those of us in the helping industry because we see some stuff and we need to work it out amongst ourselves, and we can use this gallows humor. I know it very well because I'm a nurse. We don't do this in front of patients ever because it can be taken the wrong way, certainly. We encourage cultural awareness and humility. The only difference there is the humility is just stating, I don't know everything. That means I'm going to learn from you. Why don't you tell me about your culture? Tell me about it. I don't know. This boosts the trust almost instantly. We want to listen more than we're talking. We want to listen fully instead of forming what we're going to say. We've got plenty of time to form what we got to say when someone finishes talking. And then we've got to remember that internalized stigma is a reaction to past experiences. We didn't cause that. But we might have an opportunity to offset it. Every encounter is an opportunity to model what non-stigmatic recovery could be for someone. We want to do all these things while someone is talking, and then we want to wait and form what we have to say after they're done talking, not while they're talking. We have several advocacy organizations. These are just a few. Faces and Voices of Recovery is my favorite right now. National Harm Reduction Coalition is great for people that are not yet in recovery and trying to fight stigma there. Then we have to know when we talk to people in the public, we have to think about what their perspective is, what motivates them, what they're fearful about. You can ask someone, what are you scared of? Centerstone's going to open a methadone clinic in Marion, and you don't want that. Tell me about it. What exactly are you scared of? And then we need to know someone's orientation. A lot of people that may not have a compassionate orientation may have an orientation around business and success and function, right? So we can tell them, hey, using medication-assisted recovery or getting people into recovery early, as soon as we can, is actually going to increase our bottom dollars. It's going to decrease sick days. It's going to increase retention. It's going to decrease people using drugs on the job site. It's a win-win. We need to know our motivations as well. When we're reducing stigma, why is it important to us? It's important to me because I know it affected me and I know how it felt. You could brush up on current statistics and trends. You can whip these out if you want during an argument, but try not to get upset with people. All of this can slip into political connotations and stuff. Try not to let your heart rate increase and get upset with someone, because as soon as you get upset and raise your voice, you've lost the argument and the message falls flat. So just try to keep your composure and offer evidence. And we want to remember that Maya said, people forget what we say all the time, but they're never going to forget how you made them feel. Okay. You still with me?
We are. Yes.
Okay. Yeah. So I ran right up to 3 minutes left. Are there any questions or comments?
So far, nothing in the chat. If you guys have any questions, you can throw it in the Q&A or in the chat.
One thing that I can add, since I just got a minute here, is, stigma exists within the recovery community between recovered people. If you've ever been to meetings or especially big meetings where it might be like, people coming back that were in rehab, these events for alumni and stuff, I've noticed this. People can cordon themselves off by the type of drug they used to use. So the alcoholics hang together and they have judgment towards the people who use opioids, who have judgment towards the stimulant users. Those people are dirty, not us. Those people are terrible. And it's the most ridiculous thing. It really is. And it just shows you that there's a human nature thing going on where we want to, we recognize patterns, we see differences, but we don't necessarily, when we see a difference in another population, have to act upon it and stigmatize. And there's often a little place for us to think about that. That's the hard part, is thinking about these stigmas before they pop up in your head. And I'm telling you, none of us, not a single human being, is immune to this. I can talk about this till I'm blue in the face, but I have street smarts as well, because I've seen things and been places. I'm of a certain age. Some of the things that we think of as stigmatic are actually street smarts and our ability to protect ourselves and profile other people as being dangerous or not, right? So there is a line, and you'll have to find out where that is, and it does drift over time. But the idea is stigma is often not based in good evidence. It's just based in feelings.
Tasha and Frankie said thank you for this. Erica said thank you. Getting a lot of thank you.
Everyone. I love ROSC. I'm so just thrilled to be here and very honored.
We are honored to have you as well. Seem to be no questions. So thank you everyone for joining us today. Thank you, Brent, for presenting. It was incredible. Love to have you back anytime.
Okay, you just asked.
I definitely will. Everyone, you have a great rest of your day. Thank you for joining us. Very much appreciate it.